morning, everyone. So, continue our academic fest. I would now like to welcome onto stage Dr. Srinivas Savedam sir to chair this session on acute liver failure and acute and chronic liver failure. Also, I would like to welcome Dr. Manjula, who is the head of the Department of Internal Medicine in Mallaradi Medical College. Thank you for accepting our invitation, madam.
So we start the next session. Actually, I didn't know that one of my teachers is actually going to be my chairperson. I started my postgraduate training in internal medicine at Gandhi under Madam when she was an assistant professor. I'm humbled sitting next to her. It still gives us that feeling. We'll start the first topic for the next session on refractory hepatic encephalopathy. What non-transplant options do we have by Dr. Pavan Kumar?
Thank you, sir. And I would like to thank ISCCM Hyderabad for giving me the opportunity to speak at this signature event. So, what is hepatic encephalopathy? It's basically brain dysfunction caused by liver insufficiency or portosystemic shunting, and it manifests as neurological and psychiatric abnormalities. If you look at the American Association for Study of Liver Disease grading, it can vary from minimal, where there are no overt symptoms, but only tests can show up, prove that a patient has encephalopathy, to grade 4, which is comatose with decorticate or decerebrate posturing. If we come to what is refractory hepatic encephalopathy, it is frequent episodes of encephalopathy despite being on maximal medical therapy, and it is an indication for transplant. Also, once you go to severe hepatic encephalopathy, you get into this spiral where the patient aspirates, goes into sepsis, and that causes more decompensation of the liver and all of that. So if transplant is not an option for various reasons in these patients, what are the options that we have? To better understand that, we need to understand what the pathophysiology of hepatic encephalopathy is. So essentially, hepatic encephalopathy is caused by ammonia. That's the understanding we have right now, mostly by ammonia. Essentially because of increased production in the gut, because there is a change in the microbiome of the gut, and there is decreased clearance. Usually ammonia is cleared by the liver, it's converted into urea, and also by the muscle, which converts into glutamine. Now we know that a lot of cirrhotic patients are sarcopenic, so that ability of the muscle to convert it to glutamine is decreased. And then secondarily, you have portosystemic shunting, so ammonia does not go to the liver, it just gets shunted into the systemic circulation. There are also some benzodiazepine-like molecules which are produced, which can cause altered neurotransmitter production. So what is ammonia? It is produced as a product of the intestinal bacterial mechanism, metabolism of amino acids. So a lot of times people have bleeding, and there is a lot of amino acids getting into the gut, and there is metabolism which produces ammonia. It is normally, as we said, converted to urea and converted to glutamine by muscle. So when this ammonia reaches the brain, it can form glutamine, which causes astrocyte swelling, and also GABA receptor activation, which causes neurological abnormalities. Also, there are inflammatory cytokines produced because there is increased gut permeability in cirrhotics, leaky gut, and this low-level inflammatory state causes blood-brain barrier disruption, which causes increased permeability of all of these metabolites to the brain, and it can cause cerebral edema as well. The other point which has been coming up is the change in the gut microbiome, which causes increased ammonia production. So essentially, because there is decreased intrahepatic circulation of the bile salts, you have a change in the gut microbiome, going from commensal organisms to more pathogenic organisms like Enterobacteriaceae, which feed more on the amino acids. And also there's a lot of use of proton pump inhibitors, which causes these bacteria to survive the acid of the stomach and populate the gut. Okay, so the current treatment options we have, medical treatment options we have is lactulose and rifaximin. Lactulose we know is a disaccharide which is also an osmotic laxative, so it purges the gut. But more importantly than that, it changes the gut microbiome, essentially from amino acid metabolizing bacterial uh, to a saccharide metabolizing bacteria. Okay, and then we have rifaximin, which is used as secondary prophylaxis, but it is a non-absorbable antibiotic which causes again control of the gut microbiome. The other thing that a lot of people think would work is decrease in protein intake, but the risks of that outweigh the benefits. And then obviously liver transplant is an option as we had spoken about, but if we don't have that, then these are some of the other treatment options we can use, which is polyethylene glycol, PEG, which is again purging of the gut. And studies have shown that it may be superior to lactulose in resolving hepatic encephalopathy, but the limitation is the volume of PEG you have to give a patient to purge the gut. Next, you have different chemicals like glycerin phenylbutyrate and ornithine phenylbutyrate, which essentially convert ammonia to phenylacetyl glutamine, and then which is excreted by the kidney. We've been talking about gut dysbiosis, so probiotics have been shown to either resolve HE or decrease the conversion of covert HE to overt HE. So either minimal to grade 2 or such. Then the other pathophysiology which is thought to happen is this imbalance between branch chain amino acids and aromatic amino acids, which can cause increased productions of ammonia. So branch chain amino acid supplementation may be used as an additional treatment for unresponsive encephalopathy. Okay, and then zinc. So zinc is a coenzyme in the urea cycle, and a lot of cirrhotic patients are deficient in zinc. So supplementing zinc may improve encephalopathy by increasing the efficiency of the urea cycle. And L-ornithine L-aspartate is also can be used as it converts ammonia to glutamine. Now, this is about ammonia and its how we can change its metabolism. The other part of it is the portosystemic shunting, which happens in these patients. So, if we could control those shunts, maybe we can decrease the amount of ammonia getting to the brain. So, this study is a small study in 20 patients, in which they had coil embolized, that is interventional radiology, embolized the shunts, and 100% of these patients had immediate resolution, and at 12 months, 92% of the patients had sustained improvement in terms of hepatic encephalopathy, but 6 of them developed ascites. Also, we see encephalopathy in patients who had TIPS procedure to decrease the portal pressures, and that is because you're artificially creating a shunt and increasing the shunting of the blood. So in these patients, what you can do is you can decrease the size of the shunt, but essentially what you're then doing is increasing the portal pressure, right? So you have to balance between the incidence of hepatic encephalopathy and the portal pressure. And basically many of these patients then develop ascites as secondary to the portal pressure increase and varices. Then if we come to extracorporeal therapies such as Mars and Prometheus, which uses albumin as a dialysate to kind of remove the toxins which are not being removed by the liver. So some studies have shown that use of Mars in these patients causes a 34% improvement in Mars arm as compared to only 18% improvement in the conventional or standard of care treatment arm with respect to hepatic encephalopathy. So we've been talking about gut microbiome and gut dysbiosis and all. So actually fecal microbiota transplantation, which is a treatment option for C. diff. It can also be used for patients with hepatic encephalopathy with fecal transplant. There have been multiple small studies which show that all of these patients do improve with fecal microbiota transplants. And then we've been talking about altered neurotransmitter release and all of that. So flumazenil can be used. It's a benzodiazepine antagonist, but it is a short acting and it only gives you some short term benefit with no mortality benefit in these cases. So to summarize in this slide, there are multiple interventions that we can do with which are not transplant, which have shown some benefit for patients with hepatic encephalopathy, but still a lot of studies are going on, and transplant still remains the best option for patients with refractory encephalopathy. Okay, thank you.
Thank you, Dr. Pavan Kumar, for your lucid presentations. I think